It's really nice to talk to you all. It has been a month, I think, our last meeting. Today is a different presentation. I have prepared here a specific approach on MHPSS programming during COVID-19 related to community engagement. Regarding all the aspects we could consider, I will emphasize this aspect. It should be a short presentation because we actually want today to have more space for discussion. So that's why we will have two presentations after my presentation. From Ukrainian Red Cross as well MSF.
Червоний Хрест і МСФ. Отже,
how the word supervision fits in Ukraine. When we discuss in the context of mental health, supervision has a different meaning as in an office space. In an office space, a supervisor has an authority over you. No, it's. I was just mentioning I did the greetings, so I hope you all got my greetings. And I was explaining the word supervision. I call this session today as a supervision. I don't know how that sounds in Ukraine, but in several places, there is people they mix the understanding of a clinical supervision and in the context of mental health and psychosocial support, and supervision as an authority relationship with a supervisor. Those are they have very different meanings. So when we discuss mental health and psychosocial supervision, we are discussing it's not a relation of power to the cases, but it's a space of knowledge sharing and discussion, right? So the ones here that are from the mental health field, like psychologists, mental health specialists, or psychotherapists, counselors, they probably know this concept well. But it's important to say that to not mix up that, well, these guys are trying to do a supervision of my work. No, supervision has a very different meaning in the context of mental health and psychosocial support, which is not related to power dynamics. Today I was saying that we are going to discuss, we'll give a focus on an aspect of this COVID-19 outbreak pandemic that is related to community engagement. There are a few questions that I will start with here. We see now in different places in the world a kind of a beginning of slowing down the number of cases. No? So number of cases in several places had achieved a plateau, no? and so they are still there or they are start to decrease for the several reasons of measures that have been done in different places. I mean, with the exception of Brazil and the US, you know, these both countries, my country and US, they still have a constant increase, and there are other places as well, South Africa. So there are places where the curve is still going up. But there are a few questions we should start to raise. It's being raised at the moment related to this moment of the pandemic. One, with many places, they are starting to remove the restrictions related to movements. Will it guarantee that those places are COVID-free? Other questions that are coming up, and WHO is speaking a lot about that. Is it safe for children to start going back to schools and child care services? And all those questions are for us, for this group here. How the communities, family, and governments can also prepare for a possible re-emergence of the COVID-19. As it's happening in many places, like in Australia, like in Spain. The golden question nowadays, we have so many prophets as well, social scientists, and many people discussing what will be life after all this post-pandemic situation. How will the needs of the children, which is a particular focus of attention normally from MHPSS programs. More than 70% of MHPSS programs are related to child protection and child support. So how that will be met. And what about the specific vulnerable groups? And when we talk about vulnerable groups, people, they immediately think about children, or some places they think about women, they think about people with disabilities. And we need to be careful when we label some groups as vulnerable. It's not because this is not a standard understanding, like a label that this group is vulnerable just because it belongs to that group. First of all, there is a debate around this word vulnerable groups, because it might be stigmatized. And it's important to understand that vulnerable groups, they are actually groups in situation of vulnerability. So they are not vulnerable groups, but they are groups in situation of vulnerability. Okay, so that makes us to understand that, to avoid the stigmatization of a specific group, to see as a victim. And vulnerable groups are also related to this understanding that they are. It's because they are more affected, or especially affected by a crisis situation. So, and here I present, and I shortly present to you the perspective which I would like to emphasize today, which is MHPSS as a community engagement approach. So not looking only at the individual level, but looking at the community as a way to do an intervention and to have an approach on mental health and psychosocial support to help the population to fight this pandemic. And there are a few considerations here that I'm going to pass through quick. I think you're going to receive this slide later, and you can have a look later. But the first of all is to understand that the pandemic has changed the protective systems, the formal ones, like social health, education, justice services in general, but also informal systems, like how that affects the family, how that affects the community, how that affects the neighborhoods, the relationships. And we, in that sense, it's important to understand that all those systems, they need to be adapted. It's not the same way of operating, the formal and the informal way. So we have to adapt all those systems. And that's important because there are some places that the services, they were interrupted. Mental health services, they were interrupted, and they just stopped the services without trying to adapt a new way of providing the same services. And in order to do that, it really is it involves a mapping of those services, formal and informal, but also a mapping, knowing who they are, but also understanding and planning an intervention. So in that sense, I keep saying, in the humanitarian work, the importance of emphasizing that we use what is already there. We build from existing community systems, formal and informal. We don't bring something from the outside, or at least we avoid that as a principle. This is a principle from the guidelines, but often that happens that people, they come from outside that community, and they bring their solutions from outside, without looking at what is already there and building from what is already the community. And that's why humanitarian aid can be harmful. And the principles of do no harm and using what is already in the community comes from this principle, okay? One understanding why that we should build interventions from already existing structures. First of all, is that community members, children, youth, families, older people, they are the ones best placed to identify and to respond to the risks in their own community. And here I invite you to reflect on your own community. So basically on your place, in your building, where you live. If I ask you, if you would dedicate one day of your time to think how you can identify and understand the risks around you, as well as how to better respond and strength from the perspective, a protection perspective. What would you do in that place? And for sure, your answer will be a much better answer from anywhere else, from anyone else outside of that place, outside of your area, because they don't know the internal dynamics, they don't know the place, they don't know the people. So that's a good example of looking inside is a good way to understand how it's important to involve them and why they are the best place to respond. And again, you also empower the community when you do that, because you provide a perspective to them to understand that they are protagonists responding to the crisis. So they are not victims. It's not a top-down approach where the government or the international agencies, they come and they deliver stuff, they deliver aid, they provide services. It's a relationship where you involve the community to put them in a role where they are protagonists. They are empowered to realize that what they can do is very important and should be emphasized. And here are a few strategies for community involvement, a few ideas, which related to adapting message to different groups in the different regions. So it's not one message for all, but it's really having this approach and actually helping you using the community members, involving the community members to adapt those messages in the way that they see it most appropriate. Work with key community members, and key community members here, they are not necessarily the local authorities from that place. Can be, but not always, because sometimes local authorities, they reflect power dynamics in that place that are part of the problem, not part of the solution. But in every community, you have persons that they are recognized by the community themselves as a trusted, a person that has a positive influence in that community. People where the communities, they pay respect for them. It can be professionals, can be paid or unpaid, can be volunteers, can be members from the community that are teachers, professors, can be religious leaders. It's often more than one. So it's important to approach them. And one key word here when we talk about community engagement is about listening. Listen to children, listen to the community, listen to the elders, listen to the religious leaders. So again, avoiding the top-down approach. And encouraging them to express their ideas, their concerns, their views. Then I will actually pass here quickly, but it's important as an approach when we do community engagement to identify what are the protective factors and address the risk factors. And here, especially for vulnerable ones, which should be prioritized in an intervention. And here's I will share a document where this is in. You can have a look at this. But this is a way of mapping a community engagement process. You have the protective factors and the risk factors from the social level, the society level, the community level, family level, the child level. And here in the child level, it could be others, could be other vulnerable groups like elder people that many people are talking now because they don't have access to internet, they don't have access to technology. So this is the process. You can look down, map them out, and see what are the risk factors that need to be addressed and what are the protective factors that should be emphasized. Those are the two documents. I would recommend you to have a look. I will share with Alisa and Oksana. Working with communities to keep children safe. Yes, it is focused to child protection, but you will notice that both documents, they are quite useful research because it gives ideas that it helping those protecting children protect the whole community. and that's the reason I would recommend you to have a look. And yeah, those two documents are quite useful, and they have a lot of ideas related to community engagement in terms of MHPSS. And I'll tell you one example before we move on to the two presentations we have today, and then we can back to all those principles by the end of the session today for the last 20 minutes. There is a very interesting program here in my country. You know that Brazil is perhaps you have heard about Brazilian favelas or Brazilian slum, which are areas with small areas, but with a very high concentration of people living there. It's an area where normally there are several issues related to violence, related to unemployment, related to poverty. So that's why they all live kind of that place. And there are millions of people here in Brazil living like that. Not only Brazil, I think most of the countries, they have those kind of very poor area zones, overcrowded of people. So you can imagine what does it mean to ask a community member, like a family with 10, 12 persons living in a very small house, where they all have to sleep together next to each other, where one bathroom in that area is shared by 50, 100, 200 people. You can imagine what it means to ask that community, those members, those persons, to practice social distancing. It can be even an aggression to ask them to practice social distancing when it's impossible social distancing given their dynamic, their living conditions. So everyone is worried, and it has been very difficult because together with the pandemic and the virus, it's coming another wave, which is the terrible wave of the unemployment and the social problems coming, and the recession that's coming together now with the pandemic. So one interesting way, which was an initiative not from the authorities, not from the government, it was really community-led kind of approach, is, well, one specifically community is called Paraisópolis. They have more than 100,000 people living in that favela, in that area, overcrowded. So the community leaders, given the pandemic, they start to get mobilize themselves and to protect, because they knew that if they would expect the government, the situation would be much more complicated. And they start to do several actions. One of the actions that was extremely interesting to see was they identified 450 community members out of these 100,000. They trained these 450 community members, and each of those 450 persons, they were responsible for 50 houses. It's interesting because the way that they call these 450 persons, they call them as a president. So the presidents, the 450 presidents, each of them, they were responsible for 50 houses. And they would map those houses, and that person is responsible for that 50 houses. So they would be responsible to provide support, to provide information, to monitor how they were doing, what kind of needs they would have, and refer them to the services, the social services that they would they would need in time. That creates a sense of protection. The community had a huge impact. It's having an important impact because you create a sense that I'm being cared by someone else. I'm not alone and I'm not isolated. And in fact, the number of cases in this area is smaller than in other cities, is smaller than in other regions in my own, in this own city. And the city I'm talking about is São Paulo city. 20 persons that lives in this city only. So then you can compare how the strategy of one community to another community, and this is proving to work. And this is a simple but very effective way with so many principles behind it of a community engagement to support, to address, to fight, and to start fighting, because we are still in the middle of this fight against this pandemic. So I stop here, and I'm very interested to hear how the programs and the short presentations from MSF and from the Ukrainian Red Cross, which I'm extremely thankful for your time, your availability, and your openness to share with us. So I hand over back to you, Aliza, to coordinate that process.
So we have two cases from our partners, and I will ask Yulia Yushchenko, from head of PSS unit from Ukrainian Red Cross Society, to present their case. I know that Yulia have some slides, so if it's possible to help Yulia to share the screen.
Hi everyone, my name is Yulia Yushchenko. I'm the head of psychosocial support in the Red Cross Society, and I prepared a small presentation about how we adapted our programs to COVID-19, what we've done. Maybe it might be useful for someone else. So basically, I will talk not about a particular program, but mostly activity we do. The Red Cross in Ukraine, the Ukrainian Red Cross Society, works mostly on the first and the second level of the pyramid, which means that we are working not with individuals, but mostly in groups. And that's why the COVID-19 and the quarantine affected us a lot. So please tell me if the noise is too much. I will do something. I will shout at someone. I will show a small presentation and talk about it. Okay. Okay, thank you very much. So we had a huge 4-year program aiming to support the vulnerable groups in Ukraine who were affected by the conflict. And we had a lot of indicators in psychosocial support and social cohesion activities, meaning some social events which were impossible during the quarantine. And all we've done were focused mostly on stress relief, some social connectedness, more about social component of PSS and psycho. And as you can see, we in 2018 we worked in all yellow marked regions, and we reached around 21,000 of beneficiaries, and we did a lot. And the quarantine had us made us to shorten our capacities a lot and face us with a lot of challenges. So basically what we've done to somehow adapt our activities and not lose all the beneficiaries we have. First of all, we went online. We transferred all our activities into the Zoom. The problem was that all our field coordinators are not really familiar with IT and technologies and how to use Zoom and how to use Skype. So we provided them with some tools. We are the external expert to write some recommendations, some analysis of the existing platforms, like where better to go if you have some high confidential group or where you want some mixed groups. So this lady wrote us some recommendations which I already shared with the MHPSS working group. And we also asked her to do some supervisions to see how our volunteers and coordinators conducting activities, how they stand up with the camera, do they follow all the necessary standards, which is a bit harder to follow online versus offline, definitely. So that's how we, for example, did the Children Resilience Program, certified program. So our volunteers with psychological background provided some Children Resilience Program activities via Zoom. What else we've done? As I mentioned, we mostly do some stress relief, some crafts, some activities with some crafts and art sessions. And our coordinators decided to make some videos, which are the links to YouTube, how to do some origami at home, how to spend your time with your child and make it occupied for a few hours. In order not to miss the PSS component of such an activities, we provided our field coordinators with some templates. So basically the video starts with some slides with questions like, how do you feel? What are your emotions? What do you want? In the middle of the process, of the art process, there are also some slides, how do you feel now? Please concentrate on the process, not on the result, and so on. And at the end of the activity, again, some questions to yourself or to your child. How do you feel? Is there any changes, and so on. What we've done else, we came up with an idea of PSS sets to help people survive through the quarantine and isolation. We asked our field officers what we should include into the PSS sets, and we made two different kind of sets. One was for elder people, and it was aimed mostly on stress relief, on support of cognitive functions. There was some as you can see, Sudoku, crosswords, and so on. And the second time was for extended families with 3 and more children. And it was for family leisure, for family cohesion, and all sets were followed with instructions how to use it to make it a PSS, right? What else we included? We actually disseminated more than 2,000 sets overall. What else we included is RCC materials in each and every set. So the translated My Hero Is You book. We also adapted a lot of Hong Kong Red Cross informational materials from MHPSS. And the second one on the slide was put into the PSS sets for families. So that actually for English colleagues, it's how to support yourself and your relatives during the isolation. It has some do's and don'ts. And for elderly, we had the last one. It's a poster for elder people, how to care about themselves. It's in a big font, so it's visible, and there are some numbers and hotline numbers itself. What actually, and the third one, what we've done, we adapted our caring of volunteers and staff system, which was also based on the group activities. So we transferred them to Zoom and also provided our staff and volunteers with free of charge psychological consultation. So we did a tender and we signed the contract with one of the Kyiv services and disseminated the number of the hotline with internal channels. So what we basically achieved is, as I said, distribution. So our indicators did not suffer a lot, because anyway, we're talking about some projects and programs that we have indicators we have to reach. Another achievement is the spread of demand, I would say, on PFA, as our volunteers from all branches asked for some trainings of how to talk to people who are stressed, and if you can't see a person, how to calm them down. And I would say that the mental health stigma was pretty high within the volunteers and staff before the COVID-19. But as I can see from the statistic of request to the support, and also overall the demand on some group support is much higher than it was. Definitely we still face some challenges, and first of all is social cohesion indicators, as we couldn't continue our social events. The other challenge is internet, especially in the East. So we can't reach a lot of our beneficiaries due to the low connection. The third, and I would say the most, is that in the middle of July, people stopped attending online activities and they all want to go offline, which is not really going along with all the quarantine policies. So we need somehow adapt. We're trying to conduct some offline activities, but maybe in parks, still doing the distance and the sanitizers, but that's still we have a lot of questions whether it's reasonable, should we do that, or should we ask and somehow engage people to online activities. So that's a question to ask and to get the answer for. The questions overall we have for the future is about long-term planning, as we trying to plan some lessons learned seminars, some online training or offline trainings, some activities, but we can't do it for long term as we are waiting for the second wave of COVID-19, and the numbers are rising and rising constantly. So our long-term planning has stopped, and all we do is 1 month plan maximum, which is not really okay for the of the direction. And the other question is about the budgeting of programs and flexibility and how to adapt all indicators and budget lines and all M&E, actually, how to count people when you do online activity for like 40 people, how to sign all the documents, how to sign all the approval on photo or video, and so on and so on. That's basically, I would say, all from my side. If you have any questions, I'm open and free to answer.
Thank you very much for this very interesting presentation. Before we move, what are the key aspects that you think is already a kind of lesson learned for you over this process of all these adaptations, all those challenges, the types of, it's a big shake in your program and the way of doing MHPSS programming, especially for the Red Cross, which they have a very, let's say, a proper style of work, a continuous approach, So I ask you, what would be your reflection so far, even it's still not ready as a lesson learned, but what you are learning out of this process in terms of so far in terms of MHPSS programming that has been a value for you to discover or surprise? Well, I did not expect, or still even a frustration. Well, this is still something we can't adapt.
I would be able to fully answer your question in a week, as we have a lessons learned workshop next week. But overall, from my side, it was a great lesson that we have to pay more attention to the digital side of work we do, as it was a gap. I mean, we didn't know how to proper SMM, how to go online, and it was a great lesson for our field coordinators mostly. The second one, I would say, it's actually we learned how to be flexible. And the third and the most important is that we started to ask our field coordinators and volunteers more. As I would say, from Kiev, it's hard to quickly adapt your activity for the needs and for the reality in the field. And for example, for our PSS sets, the content and what is in them the list were done in few days just by asking the coordinators who asked the people. So the community engagement in this. What I basically am trying to say that we used to work with some standards and some recommendations from the Danish Red Cross and from some international organizations, but it takes some time to get them, to write them, to approve them, to get them here in Ukraine. And the better way to do an emergency is actually to ask people what they need and what they can do, and rely on some needs and resources we have. If I answered your questions, I tried my best.
It's very important what you just said. This big shake and the need to be flexible, to adapt, and asking everyone around to quickly adapt to the new situation. Thank you, Julia, for this presentation. So I would pass now back to you, Oksana.
Thank you. We'll ask our colleagues from MSF, Christian Merano, who is Mental Health Activity Manager, to present us your case, please.
So, and just a second, Oksana, let me just tell the participants here After we finish this presentation, we can open for discussions, open questions. So please do ask questions. Otherwise, we think that we have failed completely, all right? Or make a comment at least. Go ahead.
What we adapted? Well, we changed face-to-face consultations related to mental health and health promotion. We needed to change also group HP consultations. The activities that we changed, it was instead of face-to-face, well, we need to move for remote consultations. And also we focus our activities to COVID-19 response. It means health promotion in terms of giving people information related to they can put some general recommendations related to PPE on how to use the face mask, about sanitizers, about social distancing and so on, and some stress reduction techniques that we adapted to our interventions. What else would we adapt? Well, some specific protocols. There were like many protocols coming and going from WHO, from ICRC, from many other agencies. So also like internal protocols. So we adapted those protocols to our context and make them useful for our activities. Also, well, counseling material for COVID-19, we also develop a guideline on how to address specifically this COVID situation, and we develop a guideline for phone interventions because we change our face-to-face interventions mostly to phone interventions. So this is just an example of some of the activities that we implemented, and I'm going to tell you what activities actually we implemented, which is a hotline. We had a MHPSS hotline. At the beginning, we were hoping that the hotline was used for psychological support only, but when we started to put this in practice, we realized that people also were calling for other issues, like related to information about the spread of COVID and some measures that people can put in place in order to avoid. So we needed to adapt it. We need to adapt also our message to the needs of the people, and we decided to open this hotline as well for health education. It was also very interesting time in terms of referrals. We were not able to address all the needs of the people because of our own limitations and the limitations of the project. So it was very good opportunity to strengthen relationships with other NGOs, with other institutions like MOH, etc. So yes, that's what we need in order to adapt our activities to the needs of the people. This is how it worked, the hotline, how it actually is working. So the beneficiary call, we have two health promoters which are taking the calls, and they do even referrals. There is a list of referrals available, or they can also refer to our MSF psychologist who gives follow-ups in case of need, and made other referrals if it's the case, and also referrals to psychiatrists. Another activity that we implemented, it's some visits to locations, to some of the villages to promote health related to COVID. And we had this leaflet that we were delivering to people with some of the signs and symptoms of stress, some brief recommendations, and also the number of our hotlines so the people can call. And also we were delivering this poster, which again, it's just about the hotline, and it also gave us the opportunity to get in contact with people and to listen to their needs and try to address them. Apart from that, there were some medical activities, which is mostly strengthening the MOH capacity in some of the places. I will leave this presentation and you can see some articles related to the medical activities. Also, in terms of internal strengthening of the capacity of our team, we realized that it was important to give our MSF team some communication skills so they can also adapt their activities. It's not the same to talk to people like face to face than rather by phone. So we wanted them to have the necessary skills, and also for our own staff, it was a stressful moment, and it was also important to put in place some stress management techniques. So we offer them both trainings. Now, in terms of achievements, well, we were able to reach out even remote villages that we were not able to reach before. We were able to offer people some PPE, such as face masks and hand sanitizers. And we also realized that it is possible actually to do remote health promotion and mental health by phone consultations. It is not the same, but it is possible and it can be done. Some challenges that we faced and we are still facing somehow, it's psychological intervention follow-ups related also to the adherence of the treatment. It was a challenge for our psychologists to make people adherent to the treatment because, well, there was no presence and they have to cope by phone, and it was a challenge. Also, the group sessions were no longer possible, so that also was a challenge that we faced, and particularly data collection. We needed to adapt the tools to this type of interventions, and the beginning it was kind of complicated, and it took some time to adapt these tools to the needs of the activities. What's the future for implementation? Well, we still have some psychological follow-ups, and well, the hotline is still operative until the end of the year. So this is mostly it. As you can see, it's just some activities that we adapted. It was just a plan to respond to this situation, and actually, well, the MHPSS activities were the first activities to be put in place. So that's it. I hand it over.
Yes, thank you so much for your presentation, Christian. It's very interesting to see, and I see that the work that MSF is doing it's in terms of mental health. It's actually mental health interventions, most of it, and it's the 4th level of the pyramid. And it's interesting that we had today the 1st and the 2nd from the Red Cross, and the 4th level pyramid from MSF types of intervention. I found it interesting to see that you realize that, and this is the core aspect of a technical working group, is the understanding that not one agency can do it all, can respond to all the needs of the population. And a technical working group is actually has this mandate to help the different organizations to fill each other gaps. And in that sense, we have an approach, an MHPSS intervention in a crisis, where the different agencies can support each other and fill the gaps from that community. And I'm saying that because you said about referrals, and that we were not able to address the needs of the people. And so it was good to strengthen the relation, especially with MOH.
Right, that's true. With MOH and other actors like locally and other agencies, other NGOs. Yeah, that's right.
And I wonder if you could say a little bit more about the hotlines, how, not what was the hotlines, it's clear, but what was the impact of it? Did people use it? If you have some data around it? And I'm asking you because hotlines around the world has been one of the main services being provided everywhere, only as a basic support as well as a specialized intervention. Everyone's shifting for online support. And we are collecting several lessons learned already about this process. Places where it did not work at all, for several reasons, because people, there is a lot of stigma behind mental health. So for them to make a call and ask for support was, and then the service itself adapted. They start to call a hotline in a different way. So I wonder how it was for MSF and how is
Yeah,
going so far.
So yes, the hotline, it was not, I mean, we didn't receive as many calls as expected. And this is also a good lesson learned for the project, because we thought that it was a good opportunity to offer population this hotline, but maybe I don't know, because of the situation of urgency, we just did it. But probably it will be better to have maybe, you know, like focus group to see what really people need and what really people use. So that's a good lesson learned. Even though we were receiving many phone calls, most of them related to health issues, not specifically mental health. And that's also very interesting, because despite of many years of many NGOs working in the area, the understanding of people about mental health, maybe it's not as we expected. And that's also like a big question mark that we have, like why, despite many years and many agencies working in the region, mental health is still not considered something important, or people even don't know what is. So that's also part of the questions that we are asking ourselves, and also what we can do to tackle this issue. So, well, in conclusion, we received, yes, calls to the hotline, but not as many as we expected before. And but it was very, very interesting and also very helpful.
Excellent. Thank you so much, Christian. You made a question that I will give this question or reflection back to the group, because I think this is a very, very key reflection point. After so many years of intervention and activities, why it apparently seems that mental health is still not considered as an important thing in the community perspective. But before I open the floor for the group, and you might have other questions as well, you all participate in this discussion. I just want to say that next week you have a very dear person, Anita, an Italian MHPSS specialist. She will participate in the conference next week, and she's a psychologist, clinical psychologist, and she was in the front line in Italy, really working in the hospitals during that peak where everyone was looking at Italy by that time. I was calling her, she was totally overwhelmed, and then it shifted. She started calling me when it came to Brazil, the situation. So, and she was the one where I got one of the lessons learned related to hotlines, in how it failed. It was a failure at the beginning, hotlines, and how they adapted the hotlines with a different approach that it then worked pretty well. So I'm just telling you this because if she doesn't say that next week, do ask her. So what was your experience? Marcio asked to ask you, how was the experience of the hotlines in Italy? Because they had an approach which was very proactive, so they were not waiting for people to call them. And they start to call specific groups, specific persons, etc. So do get that. I won't do the spoil here, but do get that from it next week. But so I open the floor now. You can write your question in Ukrainian and don't need to be in English. You can make your question in Ukrainian as well. Don't need to be in English. So if you have a questions, my presentations, and I have a question to the group as well. No, and you can, if you would like to say some words for you all that are working for the mental health and psychosocial field in Ukraine for a long time, including Aliza, including Oksana, all of us here, because that's the atmosphere we want to have here. Is this question from Christian, does that speak to you? Do you feel identified that, well, somehow, in fact, mental health is still not perceived, and why you think that's still not perceived as something that important or needed by the population?
Correct. I could start just to share a couple of reflections from my side and open the floor for further discussion. So just to start thinking about this question, which is really great. Thanks, Christian, for that, and which is really important. I would start that with the idea that it's low awareness about mental health is not common only for Eastern Ukraine, but for the rest of the country as well. And probably to start reflection, it's good with the fact that we have almost 30 years of independence of Ukraine. And before that, we have long Soviet period, and during both, the culture of mental health was not really supported, and not many resources were invested in it. And even having 6 years of the crisis and many agencies supporting this, comparing with the historical background, probably it's I would not say not enough, but it's probably just the beginning of the process. And to add to that, I think that humanitarian actors, their area of work is mostly, I would say that not directly or not always linked closely with national developments, due to different approaches and different context and different needs. And so it worth to think how to improve these linkages. So this mental health awareness is pushed from both state sector or government sector and state actors, and both from community health sector and the different sector within national sector, and supported by international and national and NGOs working there. So I think we can think as a group how to empower this collaboration, and I think this might help to reinforce this raising awareness.
Thank you, Elisa. I think it's a very good point you just said. We need to think about the past to understand today, and there is a long background during the Soviet mentality and how mental health was perceived. And your challenge, as you well said, in terms of understanding mental health, it's the challenge in many places. Actually, most of the contexts where I worked before, I had to face that kind of challenge, because there was a lot of stigma associated to mental health, either by avoiding it at all, because it's related to mental disorders, severe cases, or by just minimizing it, saying that this is not important. I remember more than 10 years ago, one of my missions, I was speaking to a director of an important humanitarian agency. And when I spoke about the mental health and psychosocial support, he said that he called this intervention as a kind of, this is too fluffy, a soft kind of intervention in humanitarian context. It doesn't save lives. It has been a big shift since then. I'm sure you never say the same today, because there is more importance, and the different agencies realize the value of these discussion of mental health and psychosocial support in general. But let's not forget that mental health was for too long in the past related to mental disorders, mental illness, psychiatric hospitals, and psychiatric hospitals in those very terrible modalities like prisons, where people, they would have this be called as or identified with illness, mental illness, this expression, they would be put in a hospital for life. Or in many contexts, people with behaviors that would challenge the society, they would be labeled as with some kind of mental disorder, and then be put in a hospital for life. So that's the past that we challenge when we go to the community, and we start to speak that, listen, mental health is not about mental illness. Mental health is about wellness, well-being of the population, the well-being of the community. And it's not only your mental aspect, but it's how you live your life around you, the quality of your relationships around you. So then we shift it. It's really a mind shift, a mindset shift that we propose, and we understand nowadays the contribution of mental health and psychosocial support. Before, and that's the value of the pyramid, and that's why I defend so much the guidelines, because it really invites different expertise to be part of a mental health and psychosocial intervention, and different actors. So volunteers, community members, they are invited, or they are in a place, the guidelines, the IASC guidelines, the mental health and sexual support guidelines, invited, offer an understanding that those people in the line, community members, teachers, school teachers, volunteers, they play a key role in promoting well-being in the population, and so protecting the mental health of the population, and so treating the mental problems of the population. So you see, this question of why people, they don't come to my services, why they don't call the hotline, why they don't go to the clinic where there is a psychologist or a psychiatrist. All those questions I also had to face in my life when I was doing programming in different places. You'd offer a center, you see the needs of the population, people, they are struggling, they are suffering a lot, because they lost someone, because the war situation, because the children behaviors, etc. But they don't access the services. I saw that in conflict zones. And I had to learn from the difficult way to how to adapt it, because it's then you realize that how people, they perceive the services, it's so stigmatizing that if they go to the services, it somehow labels them as weak and in need of support. So to understand how that is perceived, to understand their view, and work through that, inviting to understand the profound meanings of mental health and psychosocial support interventions. Let me give you one example here. When I was working in Libya, mental disorders are the worst thing ever. It's like a life-death sentence, as it would be perceived by the population. The psychiatric hospital was literally a prison, and the families would not take a person to a psychiatric unit or psychiatric support. That said, you would have very few psychiatrists in the country, and very few psychologists, very, very few, like 4 or 5 persons for the whole country. When we developed a community intervention for mental health and psychosocial support, and we created a kind of a community health center, mental health center, kind of, nobody would come. So I invited the whole community, identified the local leaders, the local authorities, and start to speak about what that place is for. So without calling necessarily as mental health, but calling it as a well-being, a place where we strengthen relations in the community, where we support the ones that are suffering more. And they came out with a name that was very surprising. They call it Multacana. multa cana, when I asked them, but what is the meaning of multa cana? Multa cana in Arabic, and I don't know if it's the formal Arabic, but in Libya, means the place of the reunion. The place of the reunion. It's where community members, they come and they get together. So it was an expression of how, and for me, that's the translation of mental health and psychosocial intervention. We should be careful about that. There was a disaster in many disaster zones. You have a person with a jacket written in the back, psychologist, and nobody goes and talks to that person. And the person then asks, but why nobody comes to talk to me when they are actually struggling? Again, it's the same principle. To know it's different when we show that mental health and psychosocial support is also about human connection. So it's not about treatments. So this is a question, just to finish my say here. This is a question that is a proper place to have this kind of discussion and reflection. Is exactly a technical working group. It's here. So perhaps a topic of one day can be exactly that. How do we evaluate or perceive our mental health interventions, and how the population perceives mental health interventions? What are the gaps, and how to build bridges? So I just checked the time here. We have passed some time already. I don't know if people they have questions, or back to you, Oksana.
There are only questions about the materials in the chat and about the workshop of Anita Marini that you already announced, Marcia. And I will come back to those after the event via our newsletter. Yeah, so this is the updates from the chat.
Okay, I understand that the silence means you got into a very deep reflection and you are puzzled with everything that we shared, and you have no words to express your reaction by the moment. So I hope that you are gonna settle all that puzzle and reflections, and next week you're gonna pose the questions to Anita, because it's important. It is an exercise that helps presenters to understand how to go through and best understand how it was. So I think we are gonna close then. Is that correct, Anita and Lisa and Oksana? Just that before we close, ask one. So I would like each of you. We have 23 participants here. Can you write a word, just one word, in Ukrainian, in Russian, or in English? One word of what's a word for you that express the discussion we have today? If you can just write that, would be very helpful for us. Just one word. It's kind of that feedback I would do in person. If you would be all around me, I would force you to talk, which is basically asking you to say one word. So it's easy. You can type that word. And at the same time, I want to thank you all for this very interesting exercise. I wish you all the best of work in this time. We are all in the same boat. What's happening in Ukraine and what's happening in other places. We are all in the same place, in the same boat in that sense. So we are learning from each other. There is not really one say of important. There is not one approach for all. So thank you, and thank you, Elisa and Oksana, for this opportunity. I personally enjoy it very much. So back to you.
Thank you very much, Marcio. So we're still collecting. We don't close the chat since we really want to see this one, or I think a couple of words might be good as well. Yeah, it's already looks very interesting. looking forward to see you in the next webinars. For me personally, it was really interesting today to learn the experiences, international and our Ukrainian ones. So thank you, colleagues from Red Cross and MDM. Thank you very much, Marcio, again, for great facilitation. So, Oksana, if you have some last points.
No, I'll just remind you that we keep in touch via our platforms. There will be a follow-up after this workshop of those speakers whose presentations are publicly available. So yes, check your inbox for our follow-up, and next week I will also announce soon the details for Anita's workshop. Yeah, and that's it.
Yeah, and just as a very last note, I would we would not say that Marcio is not available for you anymore. So if you have any questions, and we can do follow-up workshop, I think, or even personally with you if you have any specific question regarding your program planning, adjusting, adapting to the COVID reality. So we all are available for those. So thank you very much again to you all, and have a good evening and rest of the week, and see you soon.